So I'd like to welcome everyone for joining us for this professional development webinar. My name is Stephanie Shivers, and I'm the Chief Innovation Officer and Vice President of Program Development here at Care in Kind. And I am here to introduce today's program and to thank you all for joining us. We'll get started with Dr. Piersol in a few minutes, but while folks are joining us, let me tell you a little bit more about Dr. Piersol. It's my honor to introduce Dr. Cathy Piersol, Distinguished Professor and Chair in the Department of Occupational Therapy at the College of Rehabilitation Sciences at Thomas Jefferson University in Philadelphia, Pennsylvania. Cathy has an impressive career spanning 40 years, and she's made a significant contribution as a practitioner, educator, and researcher. Dr. Piersol's dedication to implementing person and environmental approaches has profoundly impacted the field of occupational therapy, particularly in promoting activity engagement and enhancing the quality of life for elders and caregivers. Her work is centered on optimizing performance and participation for individuals living with dementia, as well as building essential skills for those who provide care and support. As the co-developer and director of Jefferson Eldercare, Dr. Piersol has been instrumental in the implementation of evidence-based service and training programs. These programs offer specialized training in dementia care across the United States and internationally, including Hong Kong, Sao Paulo, Brazil, and Delhi, India. Dr. Piersol has published extensively in peer-reviewed journals and is the co-author of 2 key resources in dementia care: A Caregiver's Guide to Dementia Using Activities and Strategies to Prevent, Reduce, and Manage Behavioral Symptoms, and the Occupational Therapy Practice Guidelines for Alzheimer's Disease and Major Neurocognitive Disorders. Please join me in giving a warm welcome to Dr. Cathy Piersol. Cathy, thank you so much for being with us tonight.
So thanks so much for inviting me. It's always a pleasure for me to talk about readiness and talk about meeting caregivers where they are, because it's such a critical part of what we do when working with people who are doing the hard work of supporting those who are living with dementia. So I look forward to just talking about this topic and certainly engaging in discussion at the end. So tonight, I want to achieve 3 objectives. I hope that you will appreciate the need to meet caregivers where they are. We'll talk more about that concept, to describe this concept of readiness to change as it relates to the caregivers of people living with dementia, and also to apply this concept of readiness, which I will describe in a set of stages, to identify specific approaches as to how we can work and help caregivers move along a readiness continuum, if you will, to engage in the process of caregiving. So I always like to provide a couple of scenarios when I do talks, because it helps just set the groundwork of who are we talking about here, who are the players, and also it makes you all think about people that you are working with currently, that you've worked with in the past. It always sparks an opportunity to relate what we'll be talking about in the presentation to what you actually do in your work. So I'm going to start with Mrs. Schultz and Julie. Mrs. Schultz, who lives with Julie, was recently returned home from rehab after falling at home. When she fell, she broke her wrist, she sprained her lower back, but most significantly, she had a change in her mental status. Prior to the hospitalization, Mrs. Schultz was attending an adult day center. Her daughter had it down to a routine in taking her there. But Julie has decided to, initially when her mom comes home, to take a short leave of absence from work to directly care for her mom for a little bit before she goes back to that routine. Since returning from the rehab center, Mrs. Schultz has become a little bit more resistant to taking a shower. She's been saying to Julie, I don't need a shower, or I'm already showered. This is new to Julie. due to everything else that she has to do in her life, she has been rushing her mom, unbeknownst to her in a way, but rushing her mom to get ready in the morning, and has been met with some resistance from her mom, and it's now developing into some agitation and just becoming a little bit aggressive. And then many mornings, the situation has escalated to the point where Julie is so frustrated that she has lost her temper, which of course, what does that do? That makes Julie after the fact feel terrible about doing that. And she has shared with providers that she knows that her mom is doing this on purpose and she's just wanting to drive her crazy. So thinking about Julie now, we're focused on Julie here. Some questions that I always like to think about the fact that I need to step back a minute and say, who is this person I'm working with? Not jumping to conclusions, even to say, wow, that's great that she took time off from work, because maybe it's not great. Maybe she did that out of desperation. What are some of the questions that would help me begin to understand where Julie is coming from and what her situation is? Has she had time to really adjust to this new situation? Her mom changed. She's not the same person that was at home before she fell. Will taking that leave of absence from work impact her routines and responsibilities at home? And if so, how will it impact? What is Julie's understanding of dementia? We got a little glimpse into that when she said, I think my mom's doing these things on purpose. And her understanding of the changes in cognition that are progressive, that are occurring with her mom. What is her understanding of that? And what is the best approach to providing Julie with the knowledge and the skills and the support that she needs? I'll talk about Mr. and Mrs. Allen. Since Mrs. Allen was diagnosed with Alzheimer's disease, which was about 5 years ago, Mr. Allen has been assuming more and more responsibility for her care. He is now having some difficulty managing her daily activities and new behavioral symptoms that are on the rise. Mrs. Allen has been asking more repetitive questions. She's tried to leave the home a few times, and she's pushing him away. She's rejecting, I don't need your help, which, as we know, with all the support he's providing, that is crushing, that his wife is pushing him away. As the Allens do not receive any in-home health, currently Mr. Allen has stopped working so he can care for his wife at home full time. Because of this, finances are strained. He's becoming increasingly isolated because he is 24/7 caregiving and shows some signs of depression. He's not sure how to engage with his wife. How do I interact with her? She's a different person. And he's concerned about their rapidly diminishing quality of life that he felt they had not too long ago. That has changed. So again, stepping back and saying, let me think about Mr. Allen. Who is he? Where is he coming from? I want to ask myself, what is Mr. Allen's understanding about Alzheimer's disease and the progressive nature, its progressive nature? Has he had time to adjust to the changes in his wife's abilities and behaviors? What is the impact on Mr. Allen's daily routine and level of stress now that he's not working? And what is the best approach, again, to providing knowledge, best approach for Mr. Allen specifically for providing knowledge, building his skills, and offering support? So with that foundation, I hope you all have thought, this reminds me of someone, or I'm currently working with someone, or we all have people in our family potentially that you are thinking of at this moment. And what we move on to talk to now can relate this information to actual work that you're doing currently in the domains where you are providing care and education. So there is a concept which I'm sure all of you have heard of, even might say yourselves, is we need to meet caregivers where they are. What does that mean? Meeting a caregiver where they are. So I just wanted to start by, to meet a caregiver where they are, we have to know who are the caregivers and where do they come from? What are they doing? What is their experiences like? This is a, a 2-hour lecture in and of itself in terms of the work that's being done to understand caregivers. But I just wanted to pull out this most recent report that came out by NCH Stats, puts out current statistics on Alzheimer's disease. And this is the most recent, 2025, and we know this, but I always find, even though we know this, that it's nice just to say it and lay the foundation here, because it always strikes me, even though I've heard the billion word, it still strikes me like, wow, this is amazing how many people and what they're doing. So we have 11.5 million caregivers in the country that provide just over $19 billion, billion hours of unpaid care, which is amazing. I can't even sometimes put my head around that. That is valued at $420 billion. That's free labor that our family members are doing. And we're not surprised to see that 60% of these folks are experiencing high stress, and that 22% are forced to leave their jobs. And the two situations and cases that I just shared with you were examples of that, different ways, one on a leave and one left the position, but that has a major impact and oftentimes is an outcome of the role that folks are playing. And some more information just to capture who our caregivers are, is that the majority of people, and I'm sure all know this, who are living with dementia live at home. They're not in facilities, they're living at home, and they're cared for by their families, friends, or neighbors. And certainly as the disease progresses, they need more supervision and assistance with daily activities. 70% of caregivers do report that coordinating care is stressful. Coordinating between health appointments, coordinating multiple people coming into my house is very stressful. 60% of caregivers report that it's difficult finding resources and supports for the specific needs that they have. 74% report that a concern about maintaining their own health and becoming a caregiver, which oftentimes is the first thing that goes. I no longer go to my annual appointment because I'm too bogged down in what I have to do for my mom or for my husband. And then 40% of caregivers are suffering from clinical depression. And I think that's a significant number there, are suffering from clinical depression or high stress due to the demands of caregiving. So that's who we are talking about here. We're talking about a group of people who are doing good work, are giving of themselves to care for a family member that has a disease that oftentimes is not predictable and therefore can cause a lot of stress. So what do they have to do? Caregiving, there's many responsibilities. Here's just a short list. Their caregiving responsibilities either include doing or overseeing the activities of daily living or instrumental activities of daily living that the person with dementia is doing. A major component that is most challenging is managing behavioral symptoms, managing the resources that are available once they are determined, seeking resources and then managing them. A responsibility of being that liaison between the healthcare providers that the person living with dementia is going to and seeking, being that liaison to coordinate all of that care. And then also looking at the future. Where am I headed? I'm in the moment right now caring for this person, but there is a future, and how I'm stressed about what that future will be, and I'm not sure what that future will be. So caregiver responsibilities strike this gamut, and there's many more, and I'm sure you all could share additional responsibilities that caregivers have. So to look at this from a different perspective, in terms of challenges, I want to divide caregiver challenges into two categories, if you will. I'm going to start with the blue arrows. And the blue arrows are more what a caregiver actions are that impact themselves. So I am, as a caregiver, neglecting personal self-care and healthcare. So that's a challenge for me. I'm neglecting it. I know I have to go to the dentist. It's overdue by 6 months. I made an appointment, but I had to cancel it because something happened with my mom. So I am neglecting that. It is not a high priority. That's a challenge to make it a priority. I'm challenging relationships with family members who may disagree with what is being done for mom or for dad, and the challenge of negotiating those disagreements can be very stressful. And then, of course, competing responsibilities. The two examples that I shared of cases competing between I have to work or I can't work. And once I go back to work, how am I going to juggle my work responsibilities? Another competing responsibility so often is captured in the sandwich generation, if you will. Folks, there's so many who are caring for their children and then caring for their parents, and they're right there in the middle. So there's many competing responsibilities that caregivers have. These challenges build and also cause a lot of stress. One area that I often like to highlight specifically, because it's almost caregivers don't have experience in this necessarily prior to caring for someone with dementia, and that is managing or understanding behavioral symptoms. So what we need to understand those behavioral symptoms is caregivers need new knowledge. They need new skill. Managing behavioral symptoms is typically not common sense. It's not something that that a caregiver automatically can do. Some caregivers do. Some caregivers are amazing. They have a sense of that. But oftentimes caregivers need knowledge and skills in order to address behavioral symptoms. And along with that comes a lack of or minimal confidence or self-efficacy in what they're doing. I'm not confident that I know what to do. I am not confident that I know, Julie's not confident to know how am I supposed to handle my mom when she says she already got bathed when I know she hasn't gotten bathed? How am I supposed to handle when she kind of pushes me away and says, I don't need your help? Those are the things that are most challenging for caregivers. And the literature does support this, that behavioral symptoms, along with those other, caring for someone, helping them get dressed, setting up their bedroom, making their meals, putting things setting up the kitchen table and serving them dinner. Those are responsibilities, but have much more common sense behind them. I kind of know what to do there. But managing behaviors are what is most challenging and we know those cause the greatest distress and the lowest self-efficacy or confidence, because I don't understand them. I don't understand what this means. So here's just a very, very short list of types of behavioral symptoms, which I'm sure you all are familiar with. Some are more challenging to deal with than others, but the bottom line here with all of these types of behavioral symptoms, and they're so distinct they can be so distinct by the situation that they're in. But regardless of that, caregivers need the knowledge and the skills by the work that you all are doing in order to manage these. And we want to make sure to bring this back to the topic at hand tonight is, in order to provide that need and that knowledge and skills, we need to meet them where they are. We cannot assume that a caregiver is going to jump right in and say, yeah, please tell me, how am I supposed to get my mom to go to take a shower? Tell me what to do and I'll do it. We can't assume that. We have to find out who they are and meet them where they are. So the impact of all of this, the impact of caregiving in general, results and can result in the caregiver's anxiety, depression, burden, stress, and the impact of caregiving puts caregivers at risk for their own declining health, physical and emotional health. And as we saw with Mr. Allen, social isolation, which again, here's, a catch-22, there's social isolation can trigger depression, anxiety. So all of these are potential impacts of caregiving. So how are we going to meet the caregiver where they are? How do we figure that out? Again, I'd like to start with some questions. Step back and say, let me try to understand who this person is by probing a little bit. Is the family member or the family caregiver ready and willing to discuss the situation? I'm sure you've all been in situations where you are ready to help someone. You have the knowledge, you're going to impart it, you know you can help this person, but they're not listening to you. So you have to step back, you have to stop and say, this person really is not ready right now to hear what I have to say. So we have to ask, are they ready and willing to discuss? Or what is it that they want from me at this moment? Another question, how is dementia defined and understood by family members? A critical question here. How are they defining dementia? Have you asked? Do you, through the questions you're asking, through the interview and the discussions you're having, do you have a sense of how they're defining? Do they see it as a progressive disease? Do they see it as a diagnosis that's going to get better if they get help? What is it? How are they defining that? Very important to understand. How do family members or family caregivers describe their role? Do they see themselves and do they describe themselves as a caregiver? I have worked with many folks who I've, kind of gotten myself in trouble a little bit at the beginning because I assumed they would be referring to themselves as a caregiver and have been told forthright, I am not the caregiver. I hire caregivers to take care of my husband. I'm not the caregiver. I just coordinate their care. So we have to understand how they define their role and make sure that we are sensitive to that. What does the caregiver identify as important? What do they want resources? I want to know the times that I can take my mom to the adult day center. When is it open? When does it open? When does it close? That's all they want. What is important to them at that moment? And then lastly, can I get a sense from my interactions? And we're very intuitive here, I think, as healthcare providers, to have a sense of how they're coping. And they might mask that a little bit, but as you begin to work with someone, you get a sense of how they do cope, and then you can build on that. So all this to say, we need to step back again and understand how they describe themselves, understand how they understand the way in which they understand dementia. We need to understand what they deem important and how they manage day to day. So with all of that comes a continuum, if you will, of readiness. Everyone all caregivers, I will venture to say, are at some level of readiness to engage in the process of understanding dementia, the things we just talked about. They're also at a level of readiness that allows them to learn and to implement strategies that may seem odd to them, but they're willing to change the way they do something in order to meet the need of the person that they're caring for. So there is a readiness continuum that helps healthcare providers meet caregivers where they are. And we need to understand what that continuum is and give it some definition and give it some identification with accompanying approaches, which is what I want to do now. And I want to talk first about caregiver readiness and how one way of describing caregiver readiness. There is a model, and some of you may be familiar with the trans-theoretical model by Prochaska and colleagues, which was established in the 90s, the early 90s. And the concept of readiness is really borrowed from this model that my colleagues and I have translated to its use in dementia care. And the model suggests that changing behavior, just in general, this is the model in general, that changing behavior is complex and necessitates incremental cognitive and behavioral actions on our part, on the individual's part, who are then at different levels of readiness to engage in this process of behavior change. These levels of readiness gauge the person's ability, willingness to change the way in which they're doing something. So if you look here at the graphic, we have 5 stages. We have a pre-contemplation stage. This is a person who has no intention of making change. They might be unaware they need to make a change. This is pre-contemplative. I'm not even contemplating there's an issue or that I need to do something. Moving to stage 2, there is intention to change, and the model puts a kind of a time frame on that. So within, an immediate 6 months, change is needed. And I do understand when I'm contemplating, I have bridged the gap. I do understand that there's benefit to change, that if I do change my behavior, there will be a positive benefit. Moving to preparation stage, there's now an intention, a definite intention to take action in the immediate future. I am ready to implement a strategy. I am ready to change the way in which I do something, and I am committed to doing that. Moving to action, that's when the actions occur in a very specific, overt way of modifying what I am doing in order to get a better end. So I'm willing and I'm taking the actual actions now to do that. And then, of course, the last stage is to maintain those actions and to continue on. So behavior change has resulted in a generalization of that change. We're not going back. I'm maintaining those changes that have occurred. So these stages are helpful in understanding how change can occur and the reasons behind why it can occur. And you all might know that the history behind this, the origin of the trans-theoretical model of behavior change really originated first with smoking cessation, and then with exercise. Knowing I have to exercise, that's always my example for myself. Knowing I have to exercise, knowing I have to diet, another example. Behave that, those, stopping smoking, engaging in exercise, dieting, losing weight, it must happen with intention. And this model helps to understand where a person is on that trajectory and where we need to start with working with them to make that behavior change. So I'm going to now translate this to dementia care. So we're now talking about the caregiver, and we're talking about the readiness of a caregiver to engage with you as a provider, to listen and learn, to implement approaches or strategies, which requires behavior change on their part. Caregivers do have to change what they do oftentimes in order to address especially behavioral symptoms. So you can see here that we have these four, we boiled it to 4 stages and lumped together that action and maintenance phase when we're talking about caregivers. So in several of our evidence-based programs, this is the way in which it's helpful for the interventionist, the provider, to understand where that caregiver is, so I know how to approach them properly. So caregivers can enter that relationship with the provider at any one of these stages, and they can present. They can present at one stage initially, and then when you delve a little bit deeper, they are at a little lower stage for certain things. So it does help to understand these stages, so you can kind of go between them to know where to approach a caregiver a family caregiver that you're working with. For example, a caregiver at a low readiness, so they're pre-contemplative or contemplative, may need more education first about the disease and an understanding that troublesome behaviors, for example, are not intentional. They may need to understand that, but they're not intentional, rather a symptom of the disease. And a caregiver at a low level of readiness may need more time to introduce for the provider, for us to introduce strategies like modifying the home or changing the way that they communicate. They need a little more time to do that because they have to understand first. They need the education first to understand about dementia and how it's impacting their family member. Whereas caregivers at a high level of readiness tend to be those that are already taking action, right? They've modified the home. They removed sharp objects already. They removed a couple of chairs because the person was tripping on them. They've taken action already. Often these types of caregivers are placed in a box that says, really doesn't need me. They're already doing everything that they need to do. But I always argue that caregivers at that high level of readiness can benefit from engagement with a provider to understand the whys, to name and frame why moving the chairs out of the way, why removing sharps, why changing the way I say things works. Low readiness, we don't get into that. We first have to educate about dementia. Higher readiness, that person can really use support and validation. And we can help them understand the reasons behind why the person with dementia is doing what they're doing and why it's important for me to change and why it works. So I argue that at whatever level of this continuum, they benefit from working with us. So Gidlin and Rose analyzed data from a 5-year randomized trial testing an intervention. And what they wanted to know was, what are the factors that are associated with readiness of the caregiver? And I find this interesting, not surprising, I don't think. But what they found was that high readiness, meaning the person is at that higher level of engagement and readiness, was initially associated with better caregiver mood, less financial difficulty, lower patient cognition, more behavioral symptoms. There were more, those folks initially, when their readiness was rated, were at a higher level under those circumstances. Caregivers with less financial difficulty showed greater improvement in readiness, which makes sense. Caregivers in that preparation or action stage were more therapeutically engaged and received greater intervention benefit. They were action-oriented, they were prepared, they wanted to work and engage with the provider. And then financial stability and therapeutic engagement and perceived benefits of the intervention enhance the probability of a change. In this intervention, the interventionists rate the readiness at the beginning of the intervention and at the end. So that's what that's reflecting. The caregivers were more likely to change on that continuum under these circumstances. So we know that the data supports the notion that a caregiver at a high readiness are immediately receptive to education and implementing new strategies. Whereas caregivers at a low readiness are not ready to learn new skills yet. So to try to teach, even though you know it's the best thing that could be done, if only you would just move everything off the bathroom counter, your mom is not going to throw things. But if we jump there for a caregiver who is still contemplating whether their mother even has dementia, and she thinks she's throwing things to drive her crazy, we're going to get nowhere. So we have to meet them, right? We have to meet them where they are. So at a low readiness, it's important for us to understand that. And if we try to, if they're at a low readiness, we try to meet them up here, though, we're going to be unsuccessful. We're not meeting them at the point where they're going to listen, where they're going to work with us, where they're going to see that there's something that can be done. I hope this makes sense to people. So with this foundation of the model, I'd like to now move into how do we put this model to work? How do we identify, once identified the level of readiness of a family caregiver, what do we do with that information, and how can we meet them at the point where they're going to benefit and where they're maybe not going to kick us out, where they're not going to, where we want them to come back to us. We want them still to seek our help, right, and our support. But if you're not meeting them where they are, and this is one way to do it, identifying readiness, then they're going to lose out, and you're not going to be able to accomplish what you really want to do, and that is to help the family caregiver. So essentially what we're doing when we facilitate readiness to use strategies, if we go back to the trans-theoretical model, is that we are really working towards changing the caregiver's behavior in a positive way so that they can have an influence on the outcome ultimately of the family member they're caring for. I'm going to introduce just two basic models here before going into specific approaches. This comes from my occupational therapy background of really wanting to have a sturdy foundation of conceptual models, and also to demonstrate the importance of the environment and how the role that the environment plays in this case, behavior here is the person with dementia's behavior. So very briefly, this concept of having these three domains that impact the person with dementia's behavior, or what they do. Essentially, it's what they do. What they do can be positive. They can be sitting and eating breakfast without throwing the food. They can be following directions to take a bath. They can be engaged in a leisure type activity. But they can also be hitting, screaming, resisting care, walking out the front door. So behavior is what they do. And these three domains, the person with dementia, the environment, and the caregiver, play a role in what that looks like. So in thinking about approaches, again, this talk is not about strategies to use with the person with dementia, but I like to ground even readiness in this approach when we're talking about how we are approaching a caregiver. So we want to understand the caregiver here, what they bring to the picture, and their behavior change, their strategies that they're going to implement impact the environment and the person with dementia. So thinking about this triadic model, again, can help facilitate approaches that we might take with the caregiver, if that makes sense. And then more related to this concept of readiness is a conceptual model that depicts the stress that a caregiver experiences. And it's a complex model that I've tried to simplify a little bit here to make the point that this is a process that a caregiver goes through. And caregiving, as we have said, as you all know very well, is complex and very demanding. But it starts with a person who has a background. And, you know, for example, there's a socioeconomic status, there's a family composition that goes with that background. There's the experience and the knowledge, I'll also add, to the person. So they come to the demand of caregiving with a background that we need to understand. Then they move into the process of providing care where stressors are there. This model talks about primary and secondary stressors. Primary are those challenges that are related to the changes that are going on in the person with dementia, and then an overload of responsibilities that they have. Secondarily, adding to those stressors can be conflict. These are all the things that I highlighted a little while ago. Conflict, job responsibilities, and balancing that with caregiving responsibilities, and then self-esteem, or I could say self-efficacy, confidence that the person has. These are stressors that are that weigh down, if you will, a caregiver. And then they move through that to an outcome where the outcomes can be anxiety, depression, physical health in the caregiver. However, it's not all bad news, because we have mediators, which are down in the red there. There are mediators. That means what can impact those stressors so that the outcomes are different. So mediators of stress are what we're doing, if you will, and also what the caregiver comes with. I mentioned this earlier. Caregivers come with a sense of coping already. We want to learn about what that is, what helps them cope. Caregivers potentially have social supports, neighbors, family members. Social supports can include an adult day center. They have supports that are helping mediate the stressors that are in the light blue box. And I add to this knowledge and skill. A mediator of stress is offering knowledge and skill, which is what we're all about. And that can change outcomes, can reduce the anxiety. It can prevent depression or reduce depression. It can prevent or have an impact on the physical health in a positive way. So this process, if you think about it, is we have to meet the caregiver where they are, understand their stressors, but then we're going to help mediate that by what we do. And that's why I add my own addition to this model, and that is a mediator also is identifying the caregiver's readiness level. Identifying their readiness level allows us to meet them where they are and to design engagement, design intervention, design counseling, however the types of services that you offer, designing those services so you are meeting their level of readiness at that time and possibly moving them along that continuum. So I add that as a very important mediator to modify those outcomes in a positive direction. So some general approaches that are part of that we can use when we are approaching someone and working with a caregiver and looking at where they are on that readiness continuum is to listen. Of course, active listening is so critical. We oftentimes, and I can say this as an occupational therapist because Occupational therapists always want to solve problems, and sometimes we don't take enough time to listen to what the problem is and listen to what the caregiver is telling us. We just say, well, of course, if you move this from here to here, it'll be all fine. Remove the throw rug and you don't have to worry about your mom falling ever again. But we don't listen enough. So active listening is so important. But along with that is to validate. We don't do enough validation. And I do find in training folks in different types of interventions that validation oftentimes is only linked when they're doing something right. How can I validate a caregiver who's doing nothing right? I challenge you all to find something that you can validate. The default is always caregiving is a 24/7 job. It is extremely demanding and complex, and you are doing it every day. Now, they might not be doing it the right way, in your opinion, and you're going to help them with that. But you can validate that they are putting in the time. Even the quick example I said previously about caregivers who don't want to identify themselves as caregivers. I'm not the caregiver, I hire the caregivers. Validate. You manage, you're the project manager here. You're managing 5 different caregivers coming in and out of your house. That is amazing. Validation is critical on many levels. It does help the provider understand where the caregiver is coming from. It helps with rapport, with relationship, of course, and it sets a tone where you can understand a little bit more about that caregiver and move them along. Again, that continuum of readiness. Reinforcing important information. So this is part of that educational process, is to reinforce concept. I just have 3 examples here. Behavioral symptoms are not intentional, which is oftentimes what caregivers believe. And the ways in which we help a caregiver understand that are many, but always keeping in mind that we want caregivers to understand that. That can move them along the continuum, and that helps change behavior. If they realize that mom is not throwing things on purpose, she is not, she's not screaming in the morning on purpose. Another concept that we use a lot in our work is called relax the rules, which is really kind of goes to the next item. There's no right or wrong. Relaxing the rules means if mom wants to put on polka dots and stripes, and she was the perfect dresser her whole life. This is my mom, actually. Perfect dresser, forever, matched everything. And now my mom has dementia. And now, it's like she's got the pink shirt on with, conflicting other pink colors. I'm like, oh my goodness, my mom would never do that, but that's okay. Relax the rules. She's dressed. She's happy. She's smiling. So that concept of relax the rules, please, if you haven't heard it before, please use it. It helps. We find caregivers really relate to that relax the rules. It's okay. There's no right or wrong. Mom might like to work in the kitchen, and she puts the dishes in the dishwasher in such a weird way. I can't even do it. She doesn't do it right. Does it matter? She's engaged in something. She's putting dishes in the dishwasher. That someone who says, a caregiver who's saying she's not doing it the right way, is a caregiver who's at a lower readiness, right? They need knowledge. They need education about that it's okay. There's no right or wrong. As long as the person's safe, I will say that. As long, of course, that it's a safe situation. And then engaging the caregiver through active involvement is another approach that is very helpful in moving someone along the trajectory. And by this I mean they're practicing. You might be role modeling something and then they're practicing it. You're providing specific strategies in written form that you observe them do and give them feedback. That active involvement oftentimes helps someone move along the continuum. This does not mean that talking and support groups and listening to others stories and learning from them does not move. It's complementary. But I do highlight that practicing and the modeling that oftentimes we do as providers can help a caregiver make that connection and move to the next level of readiness. So we've taken the readiness levels on the left here and linked them to, okay, now what do I do? How do I approach the caregiver? This is very small. I'm going to take each one of these on its own and go through each of these so I can highlight specific things about what you might do to work with a caregiver at each of these levels of readiness. So we'll start with pre-contemplative. And remember, this is a person who's not even acknowledging that there's an issue. It might be that the person with dementia's physician recommended that you talk to the caregiver. And the caregiver's a nice person. She's not going to say no to you. She's going to listen. She's going to talk to you. But you know right away that she's saying things like, oh no, everything's fine. I'm taking care of everything. My mom's always been this way. It's fine. She's always manipulated me. She's always made me do things that I didn't want to do. So that's kind of the common characteristic that you hear or see in a person that's pre-contemplative. So where can you start with that? As I said a minute ago, you can't start by giving strategies. You have to start by education. I'm sure all of you have various, and certainly Caring Kind has fabulous resources for education. But you have to start there. You have to meet the person where they are. They need to understand dementia. What most important for them to understand? They need to understand that it's progressive. Maybe that's what you are identifying, that they need to understand. So that approach must start with basic education. Questions like, what can I do for you? How can I help you? This could be a caregiver who doesn't believe their mom really has dementia, or that they're doing it on purpose. How could I help you? Maybe they say, well, you could actually help me find how I can get someone in my house one day a week because I have to go back to work. If that's what they're saying, you're going to try to meet them there if that's possible. And along the way, you're educating them. Questions like, what are you interested, or what are you interested in learning about? And what would make, another great question to begin the process is, what would make your situation better? That can help you a lot to understand a caregiver where they are. And also it might give you something to latch onto. You want to try to find something that you can latch onto that's going to get you in the door, if you will. Hook the caregiver to begin, because what you're trying to do here with someone at this stage is to move them to contemplative, okay? To move them to where they acknowledge there is an issue, where the caregiver does lack the knowledge about the disease, but they are aware the problem exists and they're trying to understand it. They are now seeking information. They're thinking about what they can do. They're realizing that maybe there are things that can be done. Oftentimes caregivers at this contemplative stage do still need education about what the person can and cannot do. Oftentimes, mostly caregivers overestimate, if you will, the person's abilities than what they oftentimes have. The safety and ability to do. So they believe the person living with dementia has greater capacity than what they have. Again, can be addressed through education. So these approaches are similar, but you can get a little bit further. What are your immediate concerns? What do you think are next steps? What are you thinking about, and how are you feeling at this point? And then you can get into, talk to me about what goes on a daily basis. What are the frustrations? This is where you can get into, because they are acknowledging that there are issues. What is it that is most challenging for you to understand, to do? And you can begin to identify, we would call them strategies, or begin to identify what's causing strategies and move forward once someone makes this transition to this contemplative level. Then with preparatory, remember that these folks have intention now. They want to listen, they want to learn, they're asking you questions. They're putting the puzzle together, they're seeking information. So this is where you can get into strategies like, which some of you I'm sure use, a problem-solving approach to try to understand what's causing the behavioral symptoms and then come up with strategies. A person at this preparatory stage is where they're ripe for that. They're ready to dig in and try to understand the reactions, the behavior that the person is having, and they are ready to acknowledge that they can change that behavior by changing what they do. I'm sure some of you have worked with caregivers. I can think of a few myself right now, where in working with a caregiver, when I'm thinking about a wife caring for her husband, where she all of a sudden had this absolute epiphany that she was causing her husband to get anxious because she was correcting him all the time. And in her mind, her husband would never want to do anything wrong. He was a perfectionist, and I was correcting him because that's what he would want me to do. And when she moved to this level and really understood that the way in which I am communicating, the way in which I am interacting with my husband is causing some of his anxiety, I distinctly remember crying and upset. It was a breakthrough. It was an amazing breakthrough of a caregiver who then moved to action. Preparatory, right to action. What can I do? Now I understand this connection, and I can move to implementation of strategies, if you will, or behaviors that I can do that's going to support my husband rather than cause him anxiety. And then the last stage, taking action or maintaining, as I said, we clump those together. So this is, we take the caregiver I was just describing. This is the person who is actively engaged, comes up with their own ideas. You've all worked with caregivers like this, I'm sure, where you might make a suggestion one session and the next session you come back and they've done it already and maybe they've gone beyond that. These are the caregivers who oftentimes providers will say, wow, you're doing such a great job, you don't really need me. And again, I argue that. I think there is some benefit from engagement at that level, but these are people who really are taking action. And they might have moved through this, or you might meet them at this level, okay? They might go between the action, the contemplation and preparation stage or level, and this, depending on the situation. But these folks are ready to work, and this is where you can really, I call it naming and framing the reasons why strategies work. These caregivers have the capacity to understand more. These are caregivers that maybe could be co-leaders of a support group. These are caregivers that can share and learn and help other caregivers understand. These are caregivers that are, have made the changes, are taking situations as they come and have those skills to modify their behavior, if you will, to utilize strategies appropriately as the disease progresses. So I just wanted to take that and just present, if you will, archetype. And I don't mean this as a stereotype. I mean these are like the type of caregivers that we encounter, and there's more of them. But and you all can, I'm sure, and maybe we will discuss in a minute these your experiences as well. But there's kind of types of caregivers, and they're the low readiness caregiver is often someone where, as the provider, you're feeling I cannot get to them. They're inaccessible to me. I can't figure out what's making them tick. I'm trying to wiggle my way in to and hook them, but it's a challenge. So exploring with that caregiver what they really want, why are they talking to you, is an approach. Another very powerful approach, which I haven't mentioned yet, is to use the words they use. How are they describing? Don't use technical words, and we all know that, but even more so than using, typically we say use layperson words, but use their words. If they call their family member by a certain name, or they call an area of their house something special, hear those, write those down, and reflect them back to them. That person, that's how you can maybe access them and help them move from low readiness to being that contemplative and then preparing to take action. And then in this lower readiness, things need to be as concrete as possible, and not abstract. If a caregiver reports the family member was having difficulty going from point A to point B, looking at that, you might make a concrete example. It's kind of not even related to dementia. Is what about moving this chair just a little bit to the right so it makes it easier? Very concrete. They can see that cause and effect, a strategy, something they did, had an impact on the person's ability to get to where they needed to go. Moving down to the blue. I'm sure you all have had this experience as well. There's differences in what your perspective as a provider and their perspective, the caregiver's perspective, and we're clashing a little bit. So again, we have to meet them where they are, right? So we have to understand where they're coming from. Focus on concrete goals again is an approach there. What would you like Mary to be able to do? Meet them with, respond to something that they tell you they would like to happen. Build on any current statements that the caregiver makes. If they say one little thing like, I realized yesterday that when I told my mom to put the napkin on her lap, she got upset. And actually at breakfast, I forgot to do that, and she never got upset. You don't let that go. What do? You name and frame. You say, let me stop right there. That was fabulous. Number one, you're going to validate. Number one, you didn't correct her. And look what happened. She did not have that negative reaction. So anything that happens, that's why working, as you all know, working with caregivers is complex, and it looks easy, but it really isn't, because you have to observe every moment and take advantage of every moment. But that's an example of how you build on what they're doing, what they say, and then you help them understand that to, again, move them from this low readiness to high readiness. Providing alternate strategies to those that are inappropriate. So often it's correction, or not saying positive things. Saying a positive thing, putting a light touch on a shoulder can help calm someone down. Making sure that caregivers understand or suggest that ignoring errors is okay. The example I gave a little while ago. So these are some of the things where you can focus on this difference in belief or perspective of the caregiver, which is kind of, it's more low readiness, but it's moving. They're moving, they're willing to listen. And then we have our high readiness caregivers, these master, I will call them, master caregivers. And again, that is important to say, what else could I offer this person? I can appeal to their desire to help others. They could share their stories. They can participate in intervention, participate in support groups, etc. And they can describe what they do that could give you. How have we not learned a tremendous amount for every single caregiver that we work with? I've learned so much and expanded my repertoire of strategies and approaches by working with caregivers, and it doesn't stop even after X amount of years that I've been doing this, which I will not divulge because it's too many. And these help me. Please tell me, what did you do? How did you get your mom to, you were telling me that she was refusing to get up in the morning, but now she is. What did you do? Share that with me. Show that. Show me. Tell me. So that, what does that do? It validates them. It helps them. And it, even though they're high readiness, you're taking advantage of that in some ways by learning from them. So the last thing I just wanted to share with you, which I will share with Stephanie and Pam, is it's a readiness worksheet, which I'm happy to provide for you all. And you please feel you're welcome to use it if it's helpful. And it just takes exactly what I've been talking about. It's kind of through few questions where you get to the level of readiness that the caregiver is in. And this should be done in the first, no later than the second session, I'll say, if you're working, if you're working overtime with someone, or engaged over time with someone, because their readiness will change. You want to identify what is it at the beginning of the time I'm meeting them. So then I can go to the box on the right and say, okay, this is where I should be starting. Here's the way in which I should approach. So this is just a worksheet that kind of puts together what I've just shared with all of you that might be helpful to organize, if you will, the intervention or the approach you're going to take. I shouldn't say the approach you're going to take with the family caregiver. And you can see there that typically what's nice is if you do have an opportunity to rate them, their level early on, and then you see them for a little while, and then you can rate them at the end, you can see a difference. You can see how you've moved them along that trajectory. You can share that. That's positive feedback for a caregiver. So it's just a way of, organizing your thoughts, approaches, and also monitoring or tracking the work that you're doing with caregivers. And that's where I end and open for questions. I hope this was understandable. I am going to, Steph, should I stop sharing?
I think, yes, if you haven't already. Thank you so much. Gosh, I've got notes for myself and I have all kinds of questions. Thanks for pulling up the readiness worksheet at the end there.
Yes.
Question. How do you formally assess this? And so we have kind of opened the gallery up, and so I just want to make everyone aware that if you have a question, feel free to turn your video on and raise your hand. Or if you want to put something into the chat, you're welcome to do that. Cathy, just let me say again, thanks so much for sharing this. I started working with Cathy, gosh, well over 10 years ago now, and I don't even really, blow the dust off my brain to think about what was when I first did a training with Cathy in one of her evidence-based interventions called Skills to Care, which goes over a lot of this. It's really the first time I was introduced to this concept of caregiver readiness. And it's really been a foundation in my work moving forward, because as you're trying to meet somebody where they are, I am an occupational therapist by background, and so we are the fixers and really want to, help people intentionally. And being able to gauge what a person is able to take in, so critical, because, I want to open the floodgates and I've got all kinds of ideas and I'm to help and have all kinds of information and resources, and I can, Pam talks about fire hosing, it's very easy for me to find.
Yes, that's a great concept. I love that. Yeah, fire hosing. Here, take all of this now. Yeah. Yeah.
And people just can't take it in, and so it's really been a helpful tool. So I'm wondering, does anybody have a question that they want to ask to Cathy? If not, there are a few in the comments that I can go ahead with. Cathy, one of the questions that came was, sometimes we can experience a a caregiver as being, resistant to behavior.
Mhm.
And is, within this model, are there ways, I mean, I think you mentioned them, but kind of what are some ways that we can kind of reframe that?
Yeah.
Or that language, maybe not necessarily being resistant, but, what's some different language that
Mhm.
we
I think, yeah, so someone who's being resistant to your attempts to educate or your attempts to help them, essentially, um, is someone who is at obviously a low readiness. So the art of that is to find something that has meaning for them. I think my example just a minute ago, where a caregiver, didn't put the napkin in the lap, but they didn't do it on purpose. They just forgot to do it, but they picked up on that. If you can find something like that, if you're with the person, caregiver, and the person they're caring for, and you see them do something or not do something, you highlight that. You keep it concrete. You don't go overboard. You don't do a lot of talking. You meet them where they are. And I think the questions that can get you there are, how can I help you today? How can I help you during this hour? And if how I can help you is to find a dentist for you to go to, let's do it. Let's go online and find a dentist. So you are meeting them where they are and what their needs are at that moment. When someone is at that level where they're kind of resisting, they're low readiness, they're not ready to change their behavior. They're the ones who are saying, my mom's doing this on purpose, or everything's okay. I'm just stressed out. Of course I'm stressed out, you have to identify one thing, if you can, that you could accomplish right then and there in that hour, in that half an hour. And if you can do that and you end there, we so want to keep going. We want to say, wow, you did great. Let's move on to this, or and let me give you more information and more. That's the wrong thing to do, in my opinion. Stop there and say, this was a really important session. I learned a lot from you today, and I hope that you want to come back and talk again, or I hope you want to come back again and we can go forward with other concerns that you have. So there's so many, it's like the art and science of it, Stephanie, you know what I mean? Like you're balancing out, but the point here is concrete. Meet them where they are, find out what will help them at that moment, I would say.
Right. Someone had put in the chat, and I think that you did answer a lot of this. And let me just think here. I think this was, Patricia had raised this question, what are some ideas for responding to caregivers who are experiencing being physically exhausted, emotionally exhausted?
Yes.
And I think, again, that goes to that readiness. I heard you loud and clear about validating.
Yeah. Yeah. Caregivers never get that for I'm being general, of course, but when a caregiver takes their family member to the primary care physician office, does the primary care physician ever say, so how are you doing, caregiver? What can I do for you? Never, ever, ever. And if they have siblings who are disagreeing with what they're doing, they're not getting any validation. So the more we can validate and find something, I think I said this earlier on, challenge yourself to find something that you can validate, meaning you can say something good, even though the caregiver is a disaster. Even though you walk in and you know right away, this caregiver needs so much knowledge, they're doing everything wrong, you might say to yourself, you have to find something that you can validate. It might be that their house is, if you're going to the home, their house is beautiful. This is a lovely home. Your husband must love sitting in the living room, looking around. That's validation. What is it that we can do things like that, which can maybe support their readiness, but also getting at the question around making them feel better, or giving them some accolades which they don't hear, which can, have an impact maybe on their wellness and their sense of quality of life as well.
Yeah, as you were talking there, I was thinking too about even, the example of like, your house is really beautiful, this is really beautiful. And it must be really challenging when, you have someone who's
Yeah,
not interacting with it. And
yeah, yeah.
they have historic.
Yep. And that can open the door. Or they're going to say, oh, no, that's not challenging. And then you're going to say, okay, that's fine. You're going to move on, right? You're going to move on, but that told you something.
Right. Yeah, exactly. Let's see what else have I got here. I think reinforcing the important information.
Hmm.
I love this, I put in the chat, I love relax the rules. Because I
Yeah.
have to say that to myself, to
Yes. Yes.
standard,
Yep.
not the same. There isn't a right and wrong here. Another
Yeah.
that's actually another realm is just this idea that what you're doing is good enough, right? That
Yes. Yes.
doesn't have to be perfect.
Yes.
That
Yep. Yep. And that's someone who maybe is on the preparation level where but they're doing at a level that is higher than what they need to do. So yeah, that's where the education can come in and helping them step off that a little bit and understand that that high level of doing is impacting their health and their physical well-being, their emotional well-being, and making that connection. And of course, as Stephanie knows, I'm all about the strategies. So what would a strategy be for a caregiver who is at this high peak? A specific strategy might be, it's okay if your mom takes a shower 2 times a week rather than 5 times a week. It's okay. So, I
right,
mean, and if you boil it down to a specific strategy that they can follow, it's not this abstract notion, but you take kind of an abstract idea about reducing the concept of maybe, relax the rules a little bit, and it doesn't have to be at that high level, but make it concrete by saying, why don't you only spend 2 days a week going through the challenging task of having your mom take a bath rather than the 5 you're doing?
right, right. Thanks. Quick question. I'm actually going to pull up that while you're answering this, I'm going to pull up the QR code. For those of you who are on the call, I know we've got about 5 minutes left for our time here. We do want all of you, please fill out the evaluation, whether or not you want the certificate of attendance as well, because that's helpful for us. We're grateful to the Hearst Foundation for sponsoring this, free of charge for
Mm.
um,
Mhm.
and reporting some of our evaluation is a part of what we do. So please fill out the evaluation and then the QR codes there to get a certificate of attendance. While you're doing this, while I'm pulling that up, any specific advice for working with caregivers who are maybe in hospice or kind of toward that
Mm.
spectrum? And before you answer that, let me just tell you all that we've got some great work at Caring Kind on grief. We had a presentation a couple months ago with Dr. Cathy Piersol from Utah on the grief
Mm.
for caregivers, and so I want to point that to
Fantastic.
as a resource. But Cathy, I don't know whether you've got
Yeah, I mean,
around end of life.
that adds another layer
Yeah.
to the understanding of the caregiver and the context. So, because I advocate for taking each situation as it is in this dyad, the person living with dementia and the caregiver in their environment, the triadic model because of that, when the person with dementia at the top of that triadic model is in hospice, that's an added characteristic of what I need to consider. And what does that mean for them and for the caregiver, for the family, for the environment? So it's an added, very important layer. We cannot ignore it. And we have to understand what that means to the caregiver to the family, and embed that into the approach that we're taking. So, in simple terms, the same approach, but we have to add that to our understanding of where the caregiver is coming from and where they are. Does that make sense?
Yes, absolutely. And I think also too that, I think again about, being the OT, we're very pragmatic, right?
Yeah, yeah,
And, for your high flyers, right? For those folks,
yeah,
they're in that maintenance stage and they're actually, actively implementing what you're talking about.
yes.
However, that's maybe kind of, I'm in my doer mode. And so
Hmm.
level of readiness in the doing is high.
Yes,
Level of readiness for the emotional
yes, yep, yep, absolutely.
place.
Yep,
Being able to parse those differences out, I think, is also important.
yes,
And, I know that, one of our team here, Francine, you asked the question about, does readiness change over time and how
yeah,
do you assess? And I think, the tool that
yeah.
you're using, becomes, really intuitive after time when you're
Mhm.
engaging. Readiness in this particular skill may be high, and readiness for or, in really doing practical things may be higher than the emotional, components that is
Absolutely.
relationships as well, so there are different aspects that play in here.
And I was just looking at Francine's comment, which is excellent in question. So critical. I think that the model allows for this change, and encourages, I don't know if I emphasize this enough, that you don't just say, okay, now the caregiver has moved from here, here, and here, so I never have to think of readiness again. You're really thinking about readiness every time you're interacting with the caregiver. And if you do see a change, the question is, why am I seeing that change? What happened? Is there an external force that occurred? Is it an internal force? What is going on that I'm seeing or hearing the caregiver do or say things that I thought they were beyond already? Or now I'm seeing kind of, I use the regression word, not to say negative, but just to make the example that something has happened. If I'm ignoring that, I'm not doing my job. I need to go back to that worksheet. I need to look at, you know what, they, in this area, for this topic, for what we're working on right now, something has happened. And unless I step back and ask myself these questions and meet them where they are, I'm not doing my job, and I'm not really going to be successful. So it's an excellent point. And I think that having a structured approach like the readiness to change model helps you do that, because you can go back to it and you can look at what is it telling you to do.
Right. I think too, people's abilities, they're changing, right? As they're
Yes, yes,
changing, their abilities are changing. And, again, different things can come up at different times across the continuum.
yeah,
And it may be, it's like, okay, we were going along and now this change has happened. Now suddenly,
yeah, yeah,
again, caregiver, and this is helping, this change, I'm thinking about the future differently, or
right.
thinking, oh my gosh, suddenly I thought I was going to be able to care for, my person at home. And now
Yeah,
maybe I can't. And just that
yep,
whole new layer of anxiety, question, need for a new level of knowledge and information, can
yes,
prevent,
yes,
that regression,
yep,
you saw, or as you stated. Um,
yes, yes, perfect.
so
Absolutely.
the checking in on readiness, I think over time, it's not
Yeah.
just one and done, you know.
Yeah, absolutely. I mean, yes, that takeaway, I'm so glad the question was asked and we're talking about it, because it's definitely not one and done. It is an ongoing process that can weave and wane through. But the model, if you will, helps you kind of try to understand what's happening. It gives you a foundation to try to understand. So you have some strategies, some approaches to use.
Right. And knowing even from a moment to moment, from a session to session, it's like,
Yeah, yeah,
you know, what I'm getting today is yeah,
yeah,
we're not, it's not going
yeah.
to today. It's, you know, I
Exactly.
thought we were going to accomplish this today, but this isn't going to happen today because,
Correct. Yeah. Yep. Exactly. Exactly. Yeah,
well,
that's
at our time, Kathy, again, thank you so much for this.
my pleasure.
It's really been our privilege to have you. This is such a great, you have such a wealth of information, and we're grateful that you're sharing it. And so thank you.
You're
On
welcome.
behalf of our own professional development, you know, I'll thank you in advance for the differences that we'll actually make in the families that we all serve. And so,
Yes. Thank you for all the work that you all are doing.
great, thank you.
It was a pleasure to be here.
Thanks so much. Stay tuned. Watch out for the emails that we'll send you. We've got a professional development seminar coming up on Asian Pacific Islanders next month, and it will keep going. So please sign on and circle back and share the information with your friends. So thank you so much and have a good evening.
Thank you. Take care.